session on accessing quality healthcare, the pharma community and Pakistan's journey to universal coverage. I'd like to start this talk with a little bit of context and address our audience, not only the Dawaai community that we're live streaming to, but our own team of medical professionals that work day in and day out to make sure that our customers receive the best quality healthcare and that they make sure all of our compliance is intact. So this year on World Pharmacist Day, we decided to do this for our team as well as for all medical professionals who are joining us today. And one of the reasons, one of the motivations behind a talk like this is, I think, the context of the entire year. And over the last year with the COVID-19 pandemic, we've realized that a lot of things have come to light, but one of the things that have been globally recognized is the critical role that the medical community plays in not only safeguarding our societies, but our very way of living. And foremost are the pharmacists, who not only have played a critical role, but they will continue to play a vital role in combating COVID-19 once we get vaccinations deployed and in the field in the coming months, especially for deployment at the grassroots level. So, through this session, let me give you a little bit of an idea. Before I introduce my first speaker, I would like to give you guys some context of what we're doing here and what we're aiming to achieve. So through the course of this webinar, what we're doing is we're trying to explore Pakistan's journey to achieving quality healthcare, which is inclusive. And inclusive means, it should be accessible, it should be good quality, and it should be affordable. Access to healthcare should not be a function of your socioeconomic standing or your proximity to the nearest hospital. And so really talking about the ground realities in Pakistan and what Pakistan has done so far, we'll talk about the progress we've made as a country. We'll talk about the roadblocks and the barriers that we continue to face till this day. And then we'll talk about the path forward for this country. And through this talk, through this session, we're hoping to start one of many conversations that policymakers and healthcare professionals need to continue having if Pakistan is to achieve healthcare which is truly inclusive. And for us at Dawaai, that means quality, affordability, and accessibility. So now, without further delay, I'd like to introduce our first speaker. It's a pleasure to introduce Mariam Kaisar. Mariam is the Commercial Operations Director for Emerging Pharma Markets at GSK UK, and she has 13 years of experience spanning from R&D, GMS, and commercial strategy and operations in 17 key emerging markets. Through her work, Mariam has helped build frontline resources to combat counterfeit drugs, which is a problem in Pakistan even today. But she has worked in other countries, including Nigeria, Senegal, Ghana, Kenya, and India, working alongside their governments, local pharma associations, and INGOs like the WHO. She's also helped develop digital solutions in the UAE to address the global health concern of antimicrobial resistance. And most recently, she helped deploy digital solutions in Brazil and Mexico to manage patient treatments through the deployment of a pharmacy platform, improving service delivery and alleviating the pressure on HCPs. In Pakistan, Mariam's work has spanned about the last few years, I believe 5 to 6 years, and she's worked particularly on building capacities and capabilities, specifically setting up 20 WHO-approved quality control laboratories in Pakistan, and she was given the Queen's Award for her contributions. Her on-ground experience in emerging markets has given her clear insight into how interventions need to be highly targeted and localized to the context in order to be effective. And for the pharma industry to build truly sustainable long-term solutions, Mariam believes that this targeted approach to e-health is the shift that the industry needs to maximize its impact. So Mariam, thank you for joining us. We're glad to have you, and the floor is yours whenever you're ready. Take it away. Mariam, I'm sorry, I think your mic is on mute.
There we go. Good start. Okay, thanks Nila for the introduction. Really appreciate that. Hello, everyone. So firstly, I'm delighted to be asked to join the webinar and share my experience on World Pharmacists Day on a topic that's very close to my heart. So like Nitha said, yes, in the past decade or so, I've been extremely fortunate to have been given the opportunity to work with numerous countries, but more importantly, gaining on-the-ground experience, understanding local constraints, needs, gaps, and then working with the Ministries of Health and the government and the regulators to address these gaps. So much of the work has been around building capacity and skills, using effective digital intervention to contribute to strengthening the healthcare systems in these areas. And it's really enabled me to understand the various market archetypes and what the constraints are in terms of willingness and risk appetite. So today, with the heading, today I'm going to share a case study which is in Pakistan. It's, like I said, something I'm very passionate about, and I'm going to share this case study because it really truly demonstrates how the power of collaboration and partnerships can contribute to the access of quality healthcare and medicines in Pakistan. And as it's World Pharmacists Day, of course, we need to emphasize that the role of a pharmacist is pivotal in the healthcare ecosystem, and this needs to be part of the solution more than before. So, you know, that's something that needs to be emphasized. So I'm going to quickly go through the case study. I'm going to try to be as high level without going into too much detail, and then hopefully we'll have Q&A later on. So I want to really provide the reality of some of the challenges and hurdles. I don't want to say it's all plain sailing and everything's perfect, because it's not, because we wouldn't be here, we wouldn't be thinking about all these interventions. I want to be able to share the good, the bad and the ugly, but also to share the success of how global efforts do result in better sustainable outcomes. And I use the word sustainable because sometimes my experience is you go into many countries like Pakistan, people start projects because they think it's great and but they don't actually go through with it. So it's really important that we think about sustainable solutions and models to keep them going. So I'm just going to turn back a bit. So in 2010, the 18th Amendment of the Constitution of Pakistan was passed by the National Assembly of Pakistan. This involved the devolution of about 22 federal ministries to the 4 federating units, including health. So you're probably thinking, what does this mean to the health sector in Pakistan? But actually it meant that there was no institutional structure responsible for the health sector at the federal level. The Ministry of Health was devolved under a constitutional amendment, which meant that it led to the devolution of powers to provincial governments. So those of you aware of the Ministry of Health and how it works and the different structures and functions, there was no regionalised, it became very much provincial. This also meant that the services delivery had become more compartmentalised. So things that we had to do at the provincial level was more about the associations, about regulatory, about audits. Everything became more about provinces and wasn't managed centralised. So this led to a lot of sort of like uncertainty. There wasn't much uniformity, and there was a real sense of confusion on the responsibilities and accountabilities at the federal and the provincial level. Now, amongst all of this, where people are trying to work out what the accountabilities are and how the federal works well with the provincial and then all the provinces work together in collaboration, a horrific incident took place in 2012. This led to the deaths of hundreds of cardiac patients, and this was due to a drug contamination incident. Now, as I speak, you probably think, well, why is this relevant? But you'll see towards the end the importance of what I'm trying to address here. So the drug contamination incident took place in 2012 in Lahore. In some of the local papers, it was known as the Isotab incident. It was known as the Punjab Institute of Cardiology, so the PIC incident. Hundreds of patients were bleeding from different parts of the body with dark spots, and they were admitted into local hospitals, you know, experiencing puzzling symptoms that were leading to death that actually nobody could identify, and it was uncontrollable. This mysterious event resulted in the death of more than 120 patients, of which we know, of which were recorded, and more than 1,000 patients were admitted to different hospitals in Lahore presenting internal bleeding. So as you can imagine, in Pakistan, you know, anchors and the media, the news flooded the papers across Pakistan. It was on BBC News, and if you Google BBC News and look up the drug contamination in Lahore, it's still there. In the UK, in the New York Times, it was there as well, and still people are talking about it today. So this was a big blow because this was something we no longer could control. We were completely confused with the federal and provincial responsibilities on who picks up what. Just to go back to the story then. So as a result of all of this, there was a lot of suspicion that this was due to an adverse reaction from a drug. This was due to prescribing patterns. This was due to counterfeits. This was due to substandard or contaminated drug by arsenic or heavy metals. Some people even thought it was linked to dengue, which, believe it or not, decided to present itself at this time in Pakistan too. So supplies of these dispensed medicines were retrieved from the deceased. They were retrieved from affected patients that were suffering by cytopenia. Remaining stocks at the Punjab Institute of Cardiology pharmacy store. And, you know, we had to find a way to actually deal with this situation very quickly, but it was unfortunate that the death toll was increasing rapidly and it just became a true race against time. So at the time, I was working with International Health Partners, a UK-based charity, not with my GSK hat on. I was loaned out for a year or so. And with International Health Partners, had fantastic people I was working with, you know, the chief pharmacist at the time, Trudy Hilton is someone I love, adore, and Mireille from UCL. And what we were looking at was what we were sent by the Chief Minister of Lahore. At the time, it was under the old government. Samples and tablets were sent for analytical testing, not only across the laboratories in Pakistan, but sent to the UK, to the USA, to France. And there was ongoing coordination between not only the laboratories involved, but the WHO in Pakistan and at the Geneva headquarters. And all of these efforts were taking place, but unfortunately the suspected medicine was not being identified. So it was only through personal contacts. So like I say, involved with International Health Partners, had a chief pharmacist, had various people we all knew. And there was this huge sort of like uproar. And, you know, for the chief minister to send samples overnight to us meant that we needed to do something fairly quickly because hospitals were flooded with beds of dying people. It was only through personal contacts and collaborative efforts of the UCL School of Pharmacy with the International Health Partners and being approached by the chief minister to find a suitable facility or laboratory for analysis of the tablets. So we managed to do this through people who are willing to actually analyze and allow us to use their facilities. What happened was we did rapid fingerprinting method by a fantastic person called Mireille. So rapid fingerprinting using NMR spectroscopy was used to identify the medicine, which was Isotab, an anti-angina medicine, which contained 20 milligrams of isobolbide 5-mononitrate as a suspect medicine. However, of the samples, hang on. I've just had a message say I've lost video. Can you see me now?
Yes, Mariam, you're good.
Fantastic. Sorry. Okay, so of the samples of set of tablets that was sent, there was a significant quantity of an unknown ingredient. So this is from NMR spectroscopy, by the way. So the unknown ingredient solved the mystery of the source of the unexplained deaths. And the Isotab 20 manufactured in Karachi at the time, which was procured by the PIC. So it wasn't a PIC problem. It was manufactured in Karachi and it was just procured according to processes and procedures by the PIC in Lahore. It was found to be contaminated. So thank God we identified one thing. So what we did was we send these samples to the MHRA. So further testing at the MHRA, again, through good connections, revealed that the unknown ingredient in the tablets was approximately 50 milligrams of pyriphosine, the anti-malarial per tablet. So 50 milligrams had been put into it instead of another API that should have been in this cardiac drug. So the antidote suggested by the MHRA in conjunction with the Royal Free Hospital London haematologists and under the NHS's poison centre was intravenous folinic acid. Okay, so we managed to not only find what was in this drug and which was leading to internal bleeding, but also what the antidote was. Because of our connections again with the WHO in Geneva and Pakistan, and we were at the time working with the WHO Pakistan, so we had an established relationship. Thankfully, through the WHO Pakistan, we identified local sources to require the volumes of folinic acid to save all these deaths and administer to the patients who had received the contaminated drugs. So in a nutshell, within a week of the tablets arriving in London, the agreed treatment protocols were implemented to those patients affected by an overdosage of the antimalarial, and immediate improvement was seen in most of the bisotopenic patients. So what you're probably thinking is, where are we getting to with this? Well, actually, this is a true example of a disaster. And this is a true example of, this is what can happen. But then this presented numerous opportunities. And the opportunities were where quality control labs and good manufacturing practice was probably not really under the highlight or addressed, or at the focal point, or well funded. Quality control labs became the focus point. You know, we had at the time at Shahbaz Sharif's government, we had the health department really looking to focus on what can we do more. We cannot rely on good connections. We cannot rely on getting UCL or MHRA or the WHO should a incident like this happen. So it really addressed the need to actually have an organizational body, and the DRAP, which is the Drug Regulatory Authority of Pakistan, was formed as a result of this incident. So you can see how a disaster can happen, but then it can unfold so many opportunities. Now, as this happened, we were obviously engaging with ministers, and I think every year for 5 years there was a new minister, a new health minister or a new secretary, special secretary. So there was a lot of onboarding to ensure that we had the buy-in, we had the engagement. And the MHRA had done a gap analysis for all these quality control labs, and they realized that actually none of these labs had quality management systems. Now, quality management systems are the fundamental requirement for international accreditation. So no lab in 2012 had accreditation. It required us, as in myself and other people, and bringing expertise in from the UK. And for 5 years solidly, even when I'd left IHP, I was working with the laboratories and the DRAP and the minister to see how we can address some of these gaps. Because this became such a prevalent issue for Pakistan, the chief minister at the time then brought in the United States Pharmacopoeia, who then put together a 5-year plan on how best to upscale, bring expertise into the country, take people from Lahore, from Karachi, from the Central Drugs Testing Laboratory to Pakistan, to the US to get some training. So you can see that this is weird, and we led a lot of workshops for 5 years, you know, in hotels all over Islamabad, Karachi, and Pakistan. We were leading workshops with the Pharma Bureau, and who without, I don't think we could have done much. The Pharma Bureau, the PPMA, the PPA, and we had fantastic backing. And there was a real appetite in Pakistan to change the behavior towards, actually, yes, we have a problem here, but we're open to changing. So you can see, I mean, the reason why I shared this case study, there was a huge disaster, and we couldn't obviously fathom how that could have continued had we not found what the contaminant was. But then there was a real need to say, actually, if this was to ever happen again, what skills do we have in Pakistan? What is the level or standard of our laboratories? You know, what are the regulators doing? Because this was a GMP issue, actually, we've got 700 manufacturing plants in Pakistan, local, by the way, taking out the multinationals. 700 of them, how many of them are of a standard? So it raised a lot of questions, but it was a fantastic way of addressing problems. It was a fantastic way of now seeing success. And I just want to end on the point, because I think I've got a couple of minutes, to say that in 2012, there was no lab that was accredited. Now we have from 17 to 20 laboratories, which are now ISO 17025 2017 accredited. We have 3 WHO pre-qualified, and we've got at least 4 more that should be pre-qualified and have submitted an RFI. So this just shows that working in collaboration, working in partnerships, and upscaling local skills and making local people accountable is a sustainable way of working. And this is no funding, by the way, so there was no funding from anybody. It was expertise coming in and sharing their experiences to people who were willing to learn. I think that's it from me, Nida.
Great. Thank you so much, Mariam, for sharing your experience with us. Especially, you know, it gives us some insight, not only into what's happening at the manufacturer end, but also the considerations that need to be in place when you're expanding. So for instance, Pakistan's pharma industry right now, it's upwards of $3.2 billion. And it's expanding a lot, which is a good sign. But you know, like you mentioned, just there's 700 manufacturers right now in Pakistan, and Just 5 years ago, in 2015, there were around 440. So this kind of growth, it really requires, some kind of vigilance and a systemic sort of structure which can allow us to be consistent, especially when it comes to compliance and especially when it comes to healthcare. So thank you for your talk, Mariam, and this gives me a nice segue into our next speaker session, Dr. Nadia Bukhari, and I'll be sharing Dr. Nadia's presentation from my end, but while I'm setting it up, let me just tell you a little bit more about Dr. Nadia. So Dr. Nadia has a proven track record within the pharmacy profession and is the UCL Global Pharmacy Ambassador. And along with being well reputed within the field in the UK, she's also built a global reputation with her work in countries including Pakistan, the UAE, Oman, Poland, Greece, Brazil, Portugal, Italy, and Belgium. And a lot of her work is focused on advocating the role of the pharmacist. Alongside this, her contributions have been recognized by the Royal Pharmaceutical Society, making her the youngest Asian and the youngest female to be awarded the honor. She was also the first Muslim woman to have been elected onto the National Pharmacy Board for England, which sets the strategy for the profession and holds influence on a government level. Currently, Nadia is the global lead for gender equity at the Workforce Development Hub for the International Pharmaceutical Federation, FIP, and is the chief pharmacist for doctors. So Nadia, I won't delay your speech any longer, and whenever you're ready.
Thank you so much, Nida. I hope everyone can hear me nice and clearly. First and foremost, happy World Pharmacist Day to the entire pharmacy team and to the team at Dawaai, as well as those who are watching. It's a great day for us to celebrate our successes, our achievements. Yes, there's a lot of work to be done in the pharmacy profession, especially in Pakistan. But I would like to use this opportunity to actually celebrate the great work that we're doing, to provide motivation and inspiration and encouragement on the fabulous work that we do. Because remember, we are the experts in medicines. No other healthcare professional has that unique selling point. So we really should be celebrating that. So can I have the next slide, please, Nida? So I'm going to first and foremost, as we are currently undergoing a global pandemic, highlight the role of the pharmacist and how we've really stepped up and behaved as leaders in the profession during this pandemic. And it's been clearly evident that our leadership response has been outstanding. Pharmacists have continuously been a frontline, open access healthcare profession, the experts in medicines who you don't need an appointment to see. Not only supplying medicines and managing patients' medication therapies, but also providing essential services such as diagnosing and treating minor ailments, chronic disease prevention, and monitoring chronic conditions. Pharmacists and their teams are making an incredible contribution to healthcare provision during the pandemic and have stood as leaders in the delivery of healthcare in the time of crisis. Now, when we had a total lockdown at the start of the pandemic, and it wasn't just Pakistan, it happened globally, there was an even greater dependence on pharmacists as a first point of contact to fulfill the public's healthcare needs. Many doctors' surgeries, OPD clinics, all of these were closed and they had moved on to phone appointments. And pharmacies were one of the few places that were kept open for the public, making pharmacists and their teams a fundamental healthcare provider during the outbreak. The public turned to their pharmacist, who led to the provision of support and advice during this time and remained on the forefront of public health by serving as direct points of access for their patients. Now, our role goes far and further and beyond that, because disseminating accurate, current, and evidence-based information regarding COVID-19 to the public was also a key focus for the profession. All of these additional responsibilities were rapidly taken on by the pharmacist and their teams, as well as continuing with normal service provision of medication supply and management and all the usual essential services. Can you change the slide, please? It's been an extremely busy time for the profession as a whole, who have shown great leadership traits of perseverance and diligence during this whole time. And here we can see a whole team here of female pharmacists in Pakistan who have shared their pictures with us. And we are extremely proud. And it's a high time now that we give visibility to our profession. We've risen to the challenges that COVID has thrown our way and have come through shining brighter than ever. During the pandemic, pharmacy teams have been swamped with dealing with medication shortages and procurement issues, as we know, and more importantly, meeting the needs of every patient who visits a pharmacy requiring support and advice. In the first few weeks of the pandemic, the workload had almost tripled in some areas, adding to increased pressure and burden to the pharmacy teams. However, through solid teamwork and working above contracted hours, we were able to manage patients' needs above and beyond expectations. We've had cases where pharmacists themselves have been delivering medicines to the patients, as well as managing patients' fears and concerns regarding the coronavirus, which has contributed, unfortunately, to mental health issues in some patients. We are also, unfortunately, seeing a very significant increase of domestic violence cases, which is a grave concern during the pandemic. And again, to deal with the demand, victims are being directed to speak to their pharmacies as safe zones and are able to speak to their pharmacist in confidence, who are then able to signpost them for appropriate support. In hospitals, we're seeing that pharmacists have not only been supporting the clinical care of existing patients, but also critical care of COVID-positive patients by having ready-to-use critical care drugs for use by the nursing and medical teams. The global desperation of finding a treatment for the coronavirus is increasing, as we know. And pharmacists, as I said before, being the experts in medicines, are essential in facilitating investigational evidence-based medicational studies, but are also central in the procurement of such treatments. With fake news circulating regarding breakthrough treatments that can save lives, pharmacists are best placed and have been offering the correct advice and support around medication use and risks to the public, as well as members of the healthcare teams and policymakers. The profession gained a long-awaited recognition from the government during the pandemic in the UK as a reliable, informed and credible resource and an integral part of the NHS family. And it's an acknowledgement which further boosted the morale of the profession. And in Pakistan, with the same token, the then Health Minister, Dr. Zafar Mirza, had also tweeted out and commended the pharmacists at the front lines. So being on the front lines during this time has meant that pharmacists and their teams have had to adopt precautionary measures, not only to safeguard the public, but themselves too. We have had, and I have to acknowledge here and highlight that we have had a number of very unfortunate COVID-related deaths within the pharmacy community globally. And pharmacists have placed a great emphasis on health and safety of their teams and the public. Many pharmacies have added perspex barriers at counters, incorporated social distancing protocols, limiting the number of people that enter the pharmacy, as well as hand sanitizing areas. Whilst working within COVID hotspot communities and hospitals, pharmacists have shown that as leaders in healthcare, they are knowledgeable, relentless, resilient, and courageous. So you can see now, Nida has changed the slide here. I'm now going to hone in a bit more on the work that I'm involved with in Pakistan and how we are trying to transform the pharmaceutical workforce. As Nida very kindly introduced me as the global lead for gender equity at the International Pharmaceutical Federation, I'm working very closely with FIP, as you know, is the acronym, and trying to transform the pharmaceutical workforce in Pakistan so we can have a sustainable, competent and capable healthcare workforce. We know, and WHO has said this as well, that there is no health without a health workforce, and we need to really look into that. But today on World Pharmacists Day, I say to you, there is no health without a pharmaceutical health workforce. So we are very, very important. We are an integral part of the healthcare team. So if you could kindly change the, change the slide here, please. Actually, if you go back the slide on NAWP. So one of these initiatives that I'm working on, being the gender equity lead, is the National Alliance for Women in Pharmacy. And I'm proud to say that I'm the founder and patron-in-chief for this particular organization, which is the only female-centric pharmacy organization in Pakistan. And we are a Pakistan Pharmacist Association initiative, and we are heavily supported by the International Pharmaceutical Federation. We launched back in Lahore in 2019, and we are Pakistan-wide, and we are all over Pakistan in all provinces, and we have great representation. And I'm just going to give you a quick whistle-stop tour as to why NAWP was formed and the importance it will have in pharmacy practice in Pakistan. If you can change the slide, please. Thank you. So demographic changes and rising healthcare demands are projected to drive the creation of 40 million new jobs by 2030 in the global health and social sector. In parallel, there's an estimated shortfall of 18 million healthcare workers, primarily in low and middle income countries, required to achieve the Sustainable Development Goals and universal health coverage. The global mismatch between health worker supply and demand is both a cause for concern and, like Mariam has said before, when we have concern and challenges, potential opportunities are created. Since women account for 70% of the health and social care workforce, gaps in health worker supply will not be closed without addressing the gender dynamics of the health and social workforce. The female health and social care workers who deliver the majority of the care in all settings face barriers at work not faced by their male colleagues. This not only undermines their own well-being and livelihoods, it also constrains progress on gender equality and negatively impacts health systems and the delivery of quality care. You can change the slide, please. So more women need to fill the gender gap. There are gaps in health worker supply, and these won't be closed without addressing the gender dynamics of the health and social workforce. The female health and social care workers deliver the majority of care. However, when it comes to leadership positions, when it comes to having a seat on the table, we're not seeing that representation. I'm really not here to single out the men, because our men in our profession are just as important. But as the stats are showing us, over 70% of the global health workforce are women. And for pharmacy, by 2030, over 72% of the global pharmaceutical workforce will be women. So if we're not going to mentor, inspire, train these women, we won't have a pharmaceutical workforce. So we really need to start looking into these issues, the challenges and the barriers that women are facing, especially in Pakistan, on becoming leaders. Next slide, please. Next slide, please. Oh, previous slide, Nida. So the WHO report, which has a very pertinent title, Delivered by Women, Led by Men. And this is what has instigated all the gender equity and gender equality issues when it comes to global healthcare. And obviously with my pharmacist hat on, I'm focusing more on the pharmacy side of things. So what this report highlights and identifies is that women are delivering global health, which is fantastic. However, it's the men that are leading it. Progress on gender parity in leadership varies by country and sector, and global health is predominantly led by men. So 69% of global health organizations are headed by men, and 80% of board chairs are men. Only 20% of global health organizations were found to have gender parity on their boards, and 25% had gender parity at senior management levels. Health systems will be stronger when women who deliver them have an equal say in the design of the national health plans, policies, and systems. Next slide, please. Next slide again. So now this is why the National Alliance for Women in Pharmacy was born. Next slide, please, Nida. So here you can see our launch back in 2019 in Lahore, in PPA House, so Pakistan Pharmaceutical Association's headquarters. We had over 200 women who came. It was absolutely amazing. It was outstanding. And we had lots of sessions within that. We wanted the women who were there to set the objectives of NAWP, because this is your organization. I didn't want to come and say, this is how I think it should look like. I wanted to understand what are the challenges, what are the barriers, and then come up with the possible solutions to actually tackle these challenges and barriers for female pharmacists in Pakistan. Next slide, please. So our vision is to support, enable, and recognize women pharmacists in the workplace, and to provide a supportive environment and mentorship for the advancement of women leaders. Next slide, please. Our objectives are to contribute to debate within the profession and healthcare with particular focus on women, address career and professional development issues, provide networking opportunities, examine women in healthcare issues, provide mentorship opportunities, and to liaise with global women in pharmacy. And can I just very hastily add here that yes, our focus is women, but to achieve gender equity, which then obviously in turn then achieves gender equality, we need to have the men on board. We need to be working together in order to achieve this. We're all pharmacists, and like I said, pharmacy is in our blood, and we are the experts in medicines. And to keep our profession alive, we need to support the female pharmacists within our domain, within our networks, so that we do have a pharmaceutical workforce. Otherwise, we won't have a workforce to actually deliver the quality health that we aspire to deliver. Next slide. So there's lots of ways in how we are supporting the female pharmacists, and we're doing a whole load of engagement activities. And again, International Pharmaceutical Federation have been very, very supportive. Next slide, please. And these are some of the outputs that we are also hoping to achieve, and we are closely monitoring. Next slide, please. So here you can see, we've actually been very, very busy during the pandemic at the National Alliance for Women in Pharmacy. We've published COVID guidelines for pharmacies in Pakistan, a first, and these guidelines, so this came out right at the beginning of the pandemic, endorsed by the Ministry of Health, endorsed by DRAP, Drug Regulatory Authority Pakistan, and it's also on the DRAP's website, but also our partners, FIP, Pakistan Pharmacist Association, doctors, as well as the Pakistan Pharmacy Council. In addition to that, we have identified and showcased our female pharmacists who have been true leaders during the global pandemic. So yesterday I was on a webinar with FIP and I was speaking, and Dr. Rupa Dutt was on there, who is the Director of Women in Global Health. And she mentioned that it's a priority for us to be giving visibility to our female health workforce. And this is exactly what NAWP have been trying to achieve during the global pandemic. We also have, we had launched a campaign on story sharing to produce a report on the challenges female pharmacists have been facing during COVID-19, working from home, having the children at home, not going to school, but then also, having to provide pharmaceutical care. Inshallah, publishing that report very, very soon. Next slide, please. So the pandemic, it has highlighted issues around gender equity, as mentioned, but it's also highlighted how digital technology can be a very, very powerful tool. Doctors is a leading telemedicine provider in Pakistan, where we focus on employing a predominant female health workforce. And as Nida introduced me, I am also the chief pharmacist and global gender lead at Doctors. In Pakistan, we see that 80% of medical or pharmaceutical graduates are female, but only 25% are in the workforce due to cultural, social barriers. So what we are doing is leveraging technology and offering flexibility offering flexibility to integrate them into the telemedicine healthcare delivery system. And this World Pharmacists Day, we will be announcing integrating the female pharmacists in Pakistan into our telemedicine coordinated care pathway. So not in silo, but actually part of the healthcare team, where the doctor diagnoses the patient and advises, and the pharmacist advises on the correct medication for that patient. So a very similar model that we have in the UK of a primary healthcare system. This is a first for Pakistan, and I also believe a global first, and we're very proud at Doctors, and we will be actually going live tonight at 8 p.m. PST, so do join us on Facebook, where we will be making lots of announcements, as well as celebrating World Pharmacists Day. Next slide, please. In addition to that, another piece of work that I'm heavily involved with is Equity Pakistan. So this is a partnership between UCL, Hamdard Institute of Pharmaceutical Sciences. I always forget the right way around. The British Council, and also the International Pharmaceutical Federation. So we're very, very excited. This will be inshallah launching in October. And this hub will address gender inequities and develop transformative gender and diversity policies for the pharmaceutical workforce in Pakistan. Again, I've been engaging with the Health Ministry, and myself had a great meeting with Dr. Faisal Sultan when I was in Pakistan just a couple of weeks ago. So there's a great support from the government side as well. This will form a national focus for gender balanced workforce transformation and act as a direct national link with the Global Equity Programme from the International Pharmaceutical Federation. And our aim is to create clear evidence-based strategies for addressing gender and diversity inequalities in the pharmaceutical workforce development in Pakistan, and also for continued education and training and career progression opportunities. Next slide, please. Aside from that, FIP and DRAP are in talks at the moment. So me being the representative for Pakistan for FIP, have been speaking and having some great meetings with the CEO at DRAP with regards to a partnership on how to improve pharmacy practice in Pakistan. So we are currently writing a report, identifying the gaps, identifying the challenges, and then providing some possible solutions. And I'm sure there'll be lots of questions on what those kind of challenges are and the gaps are within pharmacy practice in Pakistan. But this is something that we are very excited to be working on in collaboration with DRAP. So I'd actually like to take this opportunity to acknowledge the staggering support that we've received from the international pharmaceutical in all these initiatives in Pakistan, and for being enablers in these very, very important projects. So I'd just like to end there. I think, is there another slide there after this, Nida? Yes, there we go. So I'd just like to say once again, happy World Pharmacist Day, Pakistan. Keep shining, keep rising. You know, like I said, we're an integral part of the healthcare team, and we really should be holding our heads up very high in pride today. Thank you very much.
Thank you, Dr. Nadia. It was great hearing from you. I'd love to address some of what you said in the question and answer session. But for now, I'll move quickly to our last speaker for the session, Dr. Haider Khan. Dr. Haider is a public health professional with a master's in bioethics, and through data-driven processes, he has worked on revamping the clinical care and facility management in 125 district and tehsil headquarter hospitals across Punjab. Currently, Dr. Haider is engaged in implementation research on improving case management of childhood illnesses by lady health workers, as well as policy work on improving sexual health among migrants. A passionate educator, he has taught community health sciences, philosophy, and public speaking throughout his career. So without further delay, Dr. Haider, you can share your presentation now, and we're all looking forward to it. Dr. Haider, I believe we can't hear you. So would you turn on your mic? Perfect.
Hi, my apologies. I was on mute. Hi, everyone. My name is Dr. Haider Khan, and today I'd like to speak to you about infodemics. And in the areas where populations are not consenting to public health interventions, how do we navigate those very difficult spheres, especially where the infodemic is taking place? Now, before we talk about what the infodemic is, let's talk about why we're talking about it. One second, my screen seems to be stuck. Okay, perfect. So in June of this year, the head of the WHO spoke about how, alongside fighting the pandemic, they're also fighting an information war against a very large amount and a very, very large amount of information that's coming out, particularly during the pandemic. Things such as fake cures, things such as conspiracies as to where the pandemic originated from, things along those lines, and it's become a very major public health concern. Now, as to where this term came from, the first use of the word infodemic came in a 2003 Washington Post article. They spoke about how the SARS epidemic and efforts to reduce the effect of SARS or reduce the extent of damage caused by SARS was being hampered by information that was being spread over faxes, over pagers, and over wireless phones, quote unquote. Seems very quaint now in the context of where we are at the moment. Now, the word infodemic is a portmanteau between the words information and epidemic. So the United Nations Department of Global Communications spoke about how just this sheer volume of information can have the effect of making solutions hard to identify. It makes it hard to develop effective public health responses. And it also results in a large amount of confusion and mistrust among the general public. They've spoken about this being spread through campaigns of misinformation, wherein individuals are sharing faulty information, disinformation, which is intentional misinformation, as well as rumors, which can spread fairly organically. Now, as for the second component of this term, epidemic. So since we're talking about a public health issue that is emerging from the social media space, we might as well use public health tools in order to understand what's going on. And one of the more 101 concepts in public health is called the epidemiological triad, wherein we're looking at what are the agent factors. So using a biological illness as a proxy, if we're speaking about COVID, what are the factors of the coronavirus which liken individuals to catch it? What are the environmental factors? So the COVID is spread through droplet infection and things along those lines. And what are the host factors that make them susceptible or resistant towards an infection? And for certain diseases, there's vector in between, which mediates each of these pathways. A vector in the instance of malaria is a mosquito, something that is transmitting the infection across the environment towards the host. Now, when we're speaking about it specifically to the infodemic, we have to draw parallels between each of the terms towards our basic concepts. In the instance of the infodemic, we have to recognize the role of cell phone technology in terms of spreading misinformation. Now, cell phones have made very significant advancements since the term was initially developed in 2003, in terms of its ability to access the internet, decreasing costs of data bundles, how we are more able to see videos and pictures compared to before at a significantly lower cost, things along those lines. Including in countries such as Pakistan, roughly 67% of the population owns a mobile phone. Arguably, that is maybe more than the number of individuals who, let's say, use ORS when their child has diarrhea. More people have cell phones than that. As to what the environmental factors are, we have to recognize what are the roles of social media platforms, how these social media platforms are structured, and how that structuring can lead to groups of individuals basically being present in bubbles or in echo chambers, wherein everyone that they have added as their friend or all of their extended contacts or every single private group that they are present in is composed of individuals who have a similar mindset, which is maybe why you can see very large social media groups of flat earthers. Who could have imagined that in the 21st century, where we have satellite technology, we will have groups of individuals who believe that the earth is flat? To a large extent, this is as a result of social media spaces and how they work, and how they act as gatekeepers between you and similar like-minded individuals. Now, what are the agent factors? Memes. And not strictly memes in the context of the picture macro with text at the top and the punchline at the bottom, but even in terms of videos, even in terms of how platforms such as TikTok allow for you to use a video along a predetermined format, a predetermined joke with an already established punchline. The host factor is us and our entire set of cognitive biases, us and all of our context and our belief system and everything like that. The model that is shown is basically the model that, as in, it depicts a scenario wherein an individual is doubling down and incorrectly doubling down and escalatingly doubling down, maybe on something that is an incorrect decision. How does this manifest? Well, there are two ways that this can manifest. First of all is in the very large public protests, as can be seen in this picture, wherein individuals are going out and protesting against the face masks. That's one end of it, peaceful protests. The other end is all too familiar in a country like Pakistan. So, given all of these problems, the question comes is, what makes an intervention ethical? Is it necessary that an ethical intervention is more likely to be accepted or not? So before we answer some of these questions, let's look at some of the basic frameworks as to what constitutes an ethical intervention. So the first set of principles has been adopted from the clinical sciences, in which recognizing the importance of individual dignity, individual autonomy. In a very large number of countries, including Pakistan, individual dignity and honor and autonomy is reflected by things such as your right to privacy in your own home, if you're not engaged in unlawful activity that can warrant a police search. It is also manifests as the right of a parent to raise their child the way that they see fit. The next set of principles are beneficence and non-maleficence, which means that whatever it is that you're doing in a public health forum needs to be of a public good, and it needs to minimize public harm. As to what the differences between harm and good are in this context, maybe that's better suited to a philosophy class or a class dedicated to ethics, maybe not in a 10-minute panel discussion, but it's something we can explore in the Q&A section if you guys are interested. The next two terms are fairly unique to public health ethics. The first term is called distributive justice. Distributive justice is basically justice of how your public good or public utility is distributed into society. Are you focusing exclusively on the upper tier individuals who have financial access to a wide range of services? Are you making it equal across the board, wherein individuals with money have equal access as the poorer individuals? Or do we adopt something that's maybe more equitable than equal, wherein individuals who have a greater need are provided with greater resources? An example of distributive justice being affirmative action and things along those lines. Next is procedural justice. Are there set procedures developed, and does everyone have equal access or equal understanding of all of those procedures? In the instance where either the government or an enforcement body want to mandate a public health intervention, something such as, for example, face masks. So forcing your population to wear face masks or forcing your population to vaccinate their children under threat of penalty of law is only justifiable in certain sets of circumstances, and we call this the justificatory principles. And this terminology comes from liberal philosophy or liberal political sciences. The first concept behind it is effectiveness. Are face masks effective in curtailing the COVID pandemic? Yes. Mathematical models have shown that up to 60% of cases are reduced when I think about 80% of your public wears face masks. Are face masks effective? Yes. Is your reasoning compelling enough or not? and your reasoning may be compelling. So in the instance of COVID and face masks, we are willing to curtail the individual choice of wearing or not wearing a face mask in exchange for reducing the number of people who are infected and reducing people in certain demographics from passing away. People beyond, people our parents' age or people our grandparents' age. The government has an interest in making sure that these individuals do not die, so there's a compelling interest. Does it represent the least pathway of infringement? Possibly yes, as compared to maybe curfews being placed, as opposed to maybe punishing by law anyone who violates curfew or anyone who leaves their house, and sealing apartment complexes. By comparison, publicly mandating face masks represents the pathway of least infringement. And finally, are you being transparent in your are you being transparent with the policies and procedures that you are following? Now, along with transparency, effectiveness, the compelling reason, and the pathway of least infringement, we also have to make sure that some form of social justice is being implemented. Now, what do we mean by social justice? Is the government, whether it's an overwhelming interest or not, especially with the rise of popularist governments across the world these days, we see slight shifts in the trends of social justice. But the idea is that if we assume that there's a genetic lottery that led to us being into whatever set of privileged circumstances we're in, given that recognition, what if we lost the lottery? So we should make decisions as policymakers, or we should make decisions as individuals who are capable of making these decisions, which disregards our individual privileges and says that, okay, if I was born in X underprivileged category, I should have some form of basic protections within the model. But how does all of this tie in with what's going on now? In spite of the fact that face masks are effective, there's compelling reasons for it, it's the pathway of least infringement, there's transparency in terms of how it's implemented, and there's some degree of social justice. What do we do if the public's not accepting it? What do we do if the public is refusing to vaccinate their children? Do we send them all to jail? What do we do? And if we do, how do we stop the negative consequences from happening of health workers getting shot? This leads us to our broader question that in this context, what are we supposed to do? Now, it depends on how it is that we're viewing this infodemic. We can either view it as a public health issue. Now, if we're viewing it as a public health issue, the entire ideas of prevention and control come in, early detection come in. If we're talking about control mechanisms, we can talk about empowering communities to be more active in their health-seeking behavior, to be more aware of their health-seeking behavior. And we can empower our communities by empowering local workers within that. So within a rural-urban divide, within the context of a lot of health workers being more educated than the individuals that they are serving, speaking a different language, looking different, this whole set of factors basically means that communities may be more mistrustful of health workers than health workers often give them credit for. So if we are empowering locals within that community, and there's a large number of local bodies, as has been discussed before, maybe community pharmacists, maybe lady health workers, maybe religious leaders within all of these within these communities, approaching local power structures, engaging all stakeholders, and making sure that these stakeholders are co-designing whatever intervention it is that's present. So I think about a month ago, Africa declared itself polio-free, and I remember reading something along the lines of how in Nigeria they had approached the local religious leaders and ask them, okay, so what would make you believe that children should be vaccinated for polio? And their answer was simple. Their concern was that there would be pork products within the vaccine. So the government then started sourcing from Muslim countries with halal certification to make sure that there's no product along those lines. And it was publicly acceptable and was widely implemented. If we're viewing it as an informational issue, as in to misquote something, to misquote a blurb that is publicly in our public discourse, what balances a bad meme is a good meme. So the video that I'm showing right now is a TikTok challenge that was developed by Dettol. And what this basically involved was individuals to very catchy music washing their hands. What is the proper hand washing technique? This arguably led to a very wide dissemination of knowledge regarding hand hygiene and knowledge regarding appropriate hand hygiene measures. Now, what we have to recognize is that within our online spaces, we have a very large number of stakeholders, including e-pharmacies such as Dawaai. They have the ability to use this in a manner that they have the ability to disseminate large amounts of health information in this manner. Health workers should be able to use social media spaces effectively to effectively engage in digital communication. Finally, if we treat this as a technological issue, adding regulation and moderation on the tech side. Facebook needs to add more moderators, and they have to a large extent to varying degrees of success. So this has been my presentation. My name is Dr. Heather Ali Khan. Thank you so much for your kind attention.
So we have a few questions in-house. The most prominent question we're having regards to government agencies. So any of the speakers who can speak to this or who can answer this question, we've got one that talks about, government agencies and their role in bringing changes and better controls so that to maintain compliance in the pharmaceutical industry and to minimize issues such as the fake drug crisis. So how can we go about it? And who are the accreditors? So for instance, when Mariam talked about the labs that were accredited, is there some local body that also does quality control, or is it international, like the WHO? So if we could speak a little bit about this and how the government can make changes or what we should be expecting from them, that would be great.
Okay, we're just taking the point on what agencies can do. I mean, the thing is that the thing that's been recognized in Pakistan is there isn't these bodies around to help. So in the past 5-6 years of me working with Pakistan, they have heavily relied on the WHO, and they have heavily relied on organizations such as United States Pharmacopoeia to build even the capabilities in the DRAP. So that's one thing that where we're developing, we're progressing, but at the same time we're trying to build the skills internally to have sort of like leaders locally to be able to then do something like lead the leaders program. But we don't have as many agencies. And to say what the agencies for quality control labs are in Pakistan, there's something called the PANAC, which is associated to the DRAP. It's the Pakistan National Accreditation Association, I think. You can look it up. It's PANAC, P-N-A-C in Pakistan. So they do accreditation of laboratories, all sorts, agriculture, all industries, drugs. Like I say, DRAP is a government body. It's an organization. It's an agency. They work with a community pharmacist. They look at the supply chain. They look at GM. They look at pharmaceutical manufacturing, whether it's multinational or local. So not quite sure what you mean by agencies, but at the moment, Pakistan is heavily relying on external expertise to come in and upscale.
Okay, should I add on from my perspective?
Sure.
So Mariam's given her answer based on the sort of pharmaceutical industry, quality control of medicines, and what have you. I can only speak on behalf of pharmacy practice and the actual profession, and I can safely say that the authorities at B, for example, DRAP, Ministry of Health, are very, very supportive and want to have the external support to actually try and achieve a better quality healthcare within the pharmaceutical sector. So one thing that, as I mentioned in my presentation, that we're working on this report, and one of the sort of main things that the report identified and highlighted was with regards to the laws, the drug law, the Pharmacy Act. These all need updating. They need to not only be updated, but also implemented. And with FIP support, this is exactly what DRAP is looking to do, as well as, every community pharmacy should have a pharmacist present. So no medicine should be leaving a pharmacy without the pharmacist reviewing the prescription, counseling the patient. So these are the sort of the basic things, the foundation really of pharmacy practice, which we need to achieve in Pakistan. And to be very honest, this will take time. It won't happen overnight. And we are really working hard behind the scenes to achieve this. And I say this jokingly, but if this happens in my lifetime, then I feel like I've done my bit for pharmacy in Pakistan. But to be honest, that is the foundation, and we can't improve and include other services until we actually have the basics right. And it's so important to get the basics right to ensure that wherever there's a medicine, there's always a pharmacist present. So we really need to start advocating our role even more. And then people say to me, well, how do I advocate my role as a pharmacist? Which organization do I go to? You don't need to. We're all on social media. We should be our own advocates for the profession, and we should be highlighting our work and not only highlighting it to the public, but to others within the whole the healthcare community as well. Because I know right now, in Pakistan, from what I see, from what I hear, from the conversations I have with various pharmacy leaders, that there is a bit of a disgruntlement with regards to the value of the pharmacist. So we need to create that value, and we can only do that by showcasing our work and taking pride in the work that we do and showing that pharmacists are an integral part of the healthcare system.
There's another question here, which maybe Dr. Heather you can speak to, is how do fresh graduates, who are just getting out of their undergraduate in pharmacology, how can they connect with local communities at a grassroots level? Because with the social media loop, we're often just connected with people in our network, and it doesn't give the chance to understand community perspectives. So how would you suggest, or in your experience, how have you been successful in reaching local communities that you're working with? We'll take this as the last question. And so, Dr. Heather.
Well, going there, I guess, as in, that's the most simple answer, as in whatever your study site is, if you're simply going there and, conducting your study and then leaving, that may be not an incorrect technique compared to hiring maybe local data collectors if you're engaged in research work, maybe engaging in qualitative interviews to find out what the structures are within those communities, and then engaging with that accordingly. So the formal process is called stakeholder mapping. So one can engage in that kind of mapping.
Thank you, Dr. Heather, for that. And what I'll do is I think I should end this session now because we're over time, and it's been great. But I've taken up enough of the panelists' time as well as the audience's time. And what I'll do is I'll try to address all of the questions later. But just wrapping up, it's been a great session, and a lot of things have come to light. Not only the manufacturing end, but the training and the capacity building angle, as well as the ethical and social angle, because all of these have to be clubbed in. And as Pakistan being a developing country, we don't always have the luxury to be able to take local opinions or to talk about ethics, because we're often just scrambling for resources and trying to do our best to for healthcare provision to the people who need it the most. But these are conversations that we're hoping to continue. We want, not only in our community, but not only in our company, but in the Dawaai community as well. We encourage these kind of initiatives. We encourage these kind of conversations because it helps us in our team and it helps us do better. And it also helps everyone understand the considerations that are required when you're moving into public health and safety. Once again, thank you all for being here. Mariam, Dr. Nadia, Dr. Heather, thank you for your time. Thank you to the great audience. Thank you to the Dawaai team for sitting here patiently listening to me. We hope to do more of these soon and in the following months. And if you want to know more, you can visit our LinkedIn page or our Facebook page. We're also on YouTube, and we'll be sharing these recordings on all our channels. And if there's any more information, you can visit our website and email our customer services. So thank you all once again for being here. And with
Thanks,
that,
thank you
for inviting, and thank you, Dawaai team.
Thanks for having us.
Thank you all.